Welcome all of you who are joining us both on Zoom or on our Facebook Live. Thanks for joining us here for Gallbladder and Bile Duct Cancer Awareness Month.
And I just want to welcome everyone too. Aaliyah does such a great job putting these on. I actually have a neighbor, and I'm like Aaliyah, I don't know much about this. I'm very excited to hear Dr. Wang's presentation. I'm so happy she's with us today. I actually have a neighbor that had gallbladder cancer, so I'm going to be learning a lot today. And I see all our familiar faces. Hi, everyone. Thanks for joining. Thanks for always being so supportive.
Yes, thank you. And like Gina said, this is a cancer that we need more awareness about for sure. So huge thanks to Dr. Wang for speaking with us today. So our Webinar Wednesday series is brought to you by the University of Chicago Comprehensive Cancer Center's Office of Community Engagement and Cancer Health Equity. We try to be that bridge between our fantastic cancer researchers and clinical faculty at the University of Chicago and the communities that we serve in the Chicago area and beyond, our 5-county catchment area. So my name is Aaliyah Poulos, and I am an education outreach specialist in this office. We also have Gina Curry, who is our Director for Community Outreach and Engagement. And thank you all again for joining us today. Our speaker today is a University of Chicago Medicine gastroenterologist, Dr. Jennifer Wang, and I will let her further introduce herself. I'm going to stop sharing my screen and throw it to Dr. Wang, who can share her screen and get started. Okay, Dr. Wang's just sharing her screen. Everything okay?
Sorry, 1 second. Let me.
Sure.
Up to. Okay, does that, let me see, share. Okay, do you see it?
Yes, you're all good.
Okay,
go ahead and get started. Thank you.
Okay, can everybody hear me okay?
Perfect.
Okay, awesome. My name is Jennifer Wang. I'm one of the gastroenterology fellows at the University of Chicago. Thank you so much for inviting me to speak on gallbladder and bile duct cancer today. February is actually the Gallbladder and Bile Duct Cancer Awareness Month. Although it's not as common as breast cancer or lung cancer, the incidence is definitely on the rise and the prognosis is dismal. So I think it's really important that we talk about it. So for the next 20-30 minutes, I'll give an overview of what gallbladder and bile duct cancer is in terms of symptoms, risk factors, how they're diagnosed, and how we usually treat them. So first, let's just briefly review the anatomy. So this is the liver, this is the gallbladder. So the gallbladder is a small pear-shaped organ that sits just below the liver under the right rib cage. Its main job is to store bile. So bile is a digestive juice produced by the liver to digest fat. So gallbladder can sometimes form gallstones that can cause pain. It can sometimes get inflamed, causing fever and pain. And those are the two common reasons why people typically have their gallbladders removed. Cancer cells can also form in the gallbladder. It's rare, but very deadly. And so it's important that we have this forum to talk about it today. Bile ducts, so these are thin tubes about 4 to 5 inches long that reaches from the liver into the small intestine. So it looks like tree branches. The main job of bile ducts is to move bile from the liver and gallbladder into the small intestine. So after a meal, the gallbladder contracts and releases bile, and bile moves along the bile duct into the small intestine where it helps our body digest fat. So the cancer that starts within the bile duct is called cholangiocarcinoma. So gallbladder cancer is relatively rare in the United States, about 1.2 cases in every 100,000 people. The distribution varies geographically. It's more common in India, South America, and certain Eastern European countries. There are also ethnic differences in the incidence of gallbladder cancer. In the United States, it's more common in Native Americans and Hispanics. It's a lot more common in women, and the risk goes up as we age. The average risk at diagnosis is about 65 years old. So it's not exactly clear what causes gallbladder cancer. So a common theory is chronic inflammation leads to changes in healthy gallbladder cell DNA that leads to cancer. There are some risk factors that we know are associated with gallbladder cancer. The most common one is gallstones. So about 85% of people with gallbladder cancer had gallstones. However, not all gallstones become gallbladder cancer. So in fact, less than 1% of gallstone would eventually become cancer. And we don't really know why some people develop cancer while most people with gallstones don't have cancer. So gallbladder polyps, this is an abnormal growth that sometimes forms when a small gallstone gets embedded in the gallbladder wall. The polyps bulge inward from the inner gallbladder wall. This is usually seen on ultrasound. If the polyp is bigger than a centimeter, then we usually recommend gallbladder removal because these are more likely to be cancerous. Porcelain gallbladder is a condition in which the wall of gallbladder is encrusted with calcium and is brittle and fragile like porcelain. And this usually shows up on X-ray, and these usually requires removal as well. Some congenital anomaly of bile ducts can also cause chronic inflammation of the gallbladder leading to cancer. Other factors to consider are things that we know can cause other cancers, such as family history, smoking, and obesity. Gallbladder cancer is usually not found at an early stage because the gallbladder is located deep inside the body. So most of the time, there may be no symptoms at all. Therefore, gallbladder cancer can be difficult to detect during just routine physical exam. Sometimes gallbladder cancer is found unexpectedly after removal of the gallbladder for another reason, such as gallstones or infection of the gallbladder. When symptoms do occur, it could be pain on the right side of the abdomen, nausea, vomiting, weight loss, or jaundice, yellowing of the skin. So diagnosis is usually made on imaging. So ultrasound is good and non-invasive and cheaper than all the other imaging, but it could miss early changes of the cancer. CT and MRI are really good and really sensitive in terms of picking up any abnormality of gallbladder. Endoscopic ultrasound is an ultrasound that allows us to see the ultrasound from inside the body. PET scan is important to see if the gallbladder cancer has spread to other part of the body. In some cases, the diagnosis is made after removal of the gallbladder and see if there's cancer inside. So the first step after diagnosing gallbladder cancer is to figure out if it's limited to the gallbladder and the bile duct, or if it has spread to other organs within the body. So if the cancer is only in the gallbladder, then the surgery is the only treatment that offers a possibility of cure. So if it's just inside the gallbladder, then it's simply removing the gallbladder. If it involves the local lymph node or part of the liver, then it could mean removing part of the adjacent liver and lymph node. Sometimes surgery is also offered to provide palliative relief of symptoms. Chemotherapy is typically recommended if cancer has spread to other part of the body and disease is too advanced and patients not a candidate for surgery. Because the diagnosis is often made late in the advanced stage after the cancer has spread, the prognosis is usually very, very poor. So on average, people live for about 6 months after diagnosis. By 5 years, only 5 out of 100 people are alive after cancer was diagnosed. So next we'll switch gear to talk about cancer of the bile ducts, which are called cholangiocarcinoma. It's the second most common liver cancer. Globally, there are about 0.3 to 6 cases per 100,000 people per year. It's not as common in the United States. So each year, an estimated 8,000 people in the US are diagnosed with cholangiocarcinoma. And as you can see on the graph on the left, the number of new cases of bile duct cancer is going up every year. The reason for this rise is not known. While some environmental exposure might contribute to these changes, nothing specific has been linked. It may be due to the use of more accurate testing, so we're seeing more of it. Like gallbladder cancer, the prognosis of cholangiocarcinoma is also very poor. 5-year survival is only about 7 to 20%. So the incidence of cholangiocarcinoma varies substantially worldwide. It's more common in Eastern countries. So there are 85 cases per 100,000 people in Thailand compared to 0.4 per 100,000 people in Canada. So like gallbladder cancer, the risk goes up as we age. It's more common in men. Now remember, gallbladder cancer is more common in women. In the US, it's more common in Hispanics. There is a significant variation in cholangiocarcinoma mortality, so death rate across race. So between 2004 and 2014, the increase in cholangiocarcinoma mortality was highest among African Americans, followed by Asians and whites. The reason for the difference in mortality is not exactly clear, but it could be due to some sort of genetic or socioeconomic differences. So cholangiocarcinoma can develop in any parts of the bile duct. So the presentation or the symptoms of cholangiocarcinoma really depends on where the tumor is within the bile duct. So cancer within the liver is called intrahepatic cholangiocarcinoma. So this is the least common type of cholangiocarcinoma because it's deep inside of the liver. It's sometimes silent or could present with non-specific symptoms such as pain, fever, and weight loss. Cancer at the bifurcation of the bile duct is called hilar cholangiocarcinoma, and this is a more common type of cholangiocarcinoma because it sits at the bifurcation and blocks the drainage of bile. The common symptoms are deep jaundice and itching. As you can see in these pictures, so the whites of the eyes turn yellow and skin turns this deep jaundice. Cancer sits outside of the liver, so right outside of the liver, closer to the small intestine, is called extrahepatic or distal bile duct cancer. And so the symptoms are also jaundice. So important to know, about 25% of people have no symptoms and are diagnosed incidentally if they get a scan, ultrasound, or CT for another reason. So most people with cholangiocarcinoma do not have any obvious risk factors because, the common questions we get in clinics is usually, what is it? Like, how did I get it? Why did I get it? So most people don't actually have any obvious risk factors. About less than 30% of cases have known identifiable risk factors. The common factors that could increase a person's risk of developing cholangiocarcinoma are conditions or diseases that cause chronic irritation or inflammation of the bile ducts. So cysts of the bile duct is an abnormality that a person has from birth. Stones in the bile duct can be a risk factor just by causing irritation and inflammation. Primary sclerosing cholangitis is an inflammatory condition of the bile duct that usually affect young people and people with inflammatory bowel disease. Liver flukes are parasites that can infect the bile duct and are more common in Asia. Hepatitis B, hepatitis C are viral infections of the liver. Smoking, high alcohol use, and obesity are also risk factors. So researchers are constantly looking into ways to prevent cancer. Although there's no proven way to completely prevent bile duct cancer, you could reduce your risk by avoiding smoking, heavy alcohol use, and choosing a healthy lifestyle. And if you have pain from gallstones, could consider talking to your doctors about early gallbladder removal if you have symptoms. The diagnosis usually entails blood tests, so looking at liver function, looking at tumor markers, and imaging. So CT and MRI are really good in terms of providing details on the tumor in terms of size of the tumor, location of the tumor, and whether or not the tumor has spread to other organs. The diagnostic accuracy is influenced by location and growth pattern of the tumor. It's easier if the tumor shows up as, so this is an MRI and this is the liver. And so it's the same color except for this area. So you can see there's a darker area with brighter borders. So this is a cholangiocarcinoma inside of the liver. And so this is easier to see on imaging, but sometimes bile duct cancer can just be cancer cells within those thin little tubes, and that might not show up as well on imaging. And the gold standard, really the best test we have to confirm diagnosis biopsy, and this can be done with endoscopy. So endoscopy, or ERCP, is a very common tool our advanced endoscopists use every day. Sort of similar concept as colonoscopy, but it uses X-ray in addition to the endoscope. So this is done usually with patient under anesthesia, so general anesthesia. So you're asleep during the case. So it's a long, thin, flexible tube that's inserted through the mouth and guided through the esophagus, the stomach, and the first part of the small intestine, getting close to the bile duct. And it allows us to pass another thin little tube through the scope into the bile duct and inject dye. And then this allows us to take an X-ray and allows us to see the inside of the bile ducts. And so this is an X-ray imaging, and this is the endoscope sitting inside of the small intestine. And this is the small tube we use to thread a wire inside and inject contrast and choose an X-ray. So this is, remember the branch-like tree. So this is the bile duct. And so this allows us to gain direct access, and we can get a tissue, small tissue for biopsy to diagnose cancer. It also allows us to place stents inside of the bile ducts if there is blockage of the bile. So there are different treatment options when it comes to cholangiocarcinoma, including surgery, chemotherapy, radiation, stem placement, transplant, and different clinical trials. While considering treatment is really important to take into consideration the patient's age, overall health, medical condition, which really determine their ability to tolerate the treatment options we have to offer. Extent of cancer is really important because it could limit treatment options if it has spread widely. Ultimately, it is patient's preference and expectation that really guides treatment decision-making. So surgery is really our best treatment, is removal of the cancer cells, and is the only effective treatment. The location of bile duct cancer can make surgery difficult. So for tumor limited to the liver, it could involve removing part of the liver. So the remaining section of the liver takes over functions of the entire liver. So in some cases, the remaining part of the liver grows back to its normal size within a few weeks. So for tumor outside of the liver, this could mean removing part of the stomach, pancreas, and small intestine, and reconnecting healthy bile duct to small intestine. So for tumors that have spread to other organs or parts of the body or too advanced, then surgery would not be an option. In fact, sadly, only 20% of cases are eligible for surgery at the time of diagnosis. So some reasons why a person might not be eligible for cancer if there is significant scarring of liver caused cirrhosis, or if the tumor has invaded blood vessels or nerves around the area, or if the cancer has spread to other parts of the body. Even with surgery, so this is when we have curative intent and had clean margin and took out all the cancers, more than 60% of cases, tumor will come back within 2 to 3 years after surgery. Because of the high recurrence rate, even with surgery, people live for about 18 to 30 months after surgery. And 5-year survival, so this is a percentage of people alive after 5 years from surgery, is only 25 to 30%. The good news is researchers have found that adding 6 months of chemotherapy after surgery, so even if the surgeon said that we had clean margin, we got all the tumor out, we still keep people through chemotherapy for 6 months, and it's a pill that you take called capecitabine for 6 months after surgery. This extends survival to 53 months, so that's really remarkable. So if surgery is not an option because cancer is too advanced, then chemotherapy is usually offered, and it's usually a combination of gemcitabine and cisplatin. Median survival on chemotherapy is about a year compared to 2 months without surgery, without chemotherapy. As research in cancer evolves, we're now able to test tumors to see if there are changes or mutations in the DNA of cancer that allow us to target those cancer cells with specific therapy. Stenting is also an option, so this could be done either through the skin with a needle or with the endoscope that we had just talked about to deliver therapy directly or locally into the cancer. Another non-surgical option is radiation. So this is a special type of radiation called Transarterial Radioembolization. So this is done by our interventional radiologist, actually. So tiny little beads containing radioactive material are injected into the blood vessel that is directly feeding the tumor. So this not only cuts off the blood supply to the tumor, it also allows us to provide high dose radiation directly to the tumor at the blood vessel level to shrink the tumor. In other words, we're killing the tumors from within. Because the radiation beads are injected to the blood vessel directly feeding the tumor, we're actually sparing the surrounding healthy liver. So the median survival on this treatment is about a year. Because different treatment options have different survivals with surgery, with chemo, with radiation, studies have been done to figure out if we could combine the different treatment options to maximize survival. So this particular treatment option is for people who are not surgical candidates. Now remember, for people who are surgical candidates, that's really the best bet. But there are 80% of people who are not surgical candidates. So this is for those people. And it's combining chemotherapy. So chemotherapy upfront for 3 cycles, followed by TARE, that's the local radiation, followed by more chemotherapy to see if we can shrink tumor to the stage where it is eligible for surgery. So this plan nearly doubles survival from a year to 22 months. And at 1 year, 75% of people are still alive. And so this is the treatment option we are using at the University of Chicago for patients who are not surgical candidates. So what about liver transplant? So for the longest time, cholangiocarcinoma or bile duct cancer was considered a contraindication to transplant. So a reason not to transplant because of high likelihood for tumor recurrence. So in 1993, the Mayo Clinic actually came up with their own protocol for hilar cholangiocarcinoma. So hilar cholangiocarcinoma is cancer at the bifurcation. And so the protocol includes radiation upfront, followed by chemotherapy, and then liver transplant in select patients. It has since been replicated by 12 other medical centers in the United States, and the outcome is excellent. So compared to surgery, now remember, 5-year survival with surgery is only 25%. With liver transplant, this extends survival to 75%. For tumors within the liver, so intrahepatic cholangiocarcinoma, Houston Methodist Group actually published their data in 2018. So this is for biopsy-proven cholangiocarcinoma who is unresectable and in patients with good functional status. If the tumor is stable, meaning the tumor doesn't grow or doesn't spread on chemotherapy or radiation therapy for 6 months, then these patients are eligible for liver transplant. They evaluated, because it's such a rare disease, they evaluated 21 patients and 6 people underwent liver transplant. At 1 year, all 6 people are alive, and like 5 year, 85% survival. So that is really incredible. So in cancer care, different types of doctors often work together to create a patient's overall treatment plan that combines different types of treatments that are specifically tailored to a patient's cancer and overall health condition. So at the University of Chicago, our gallbladder and bile duct cancer team includes interventional radiologists, transplant surgeons, oncologists, liver specialists, pathologists, and advanced endoscopists. It's really a team sport. So we usually review patient scans at our weekly tumor board with different specialists to come up with a plan. And at our tumor clinic, you will meet the different specialists to go over each treatment option and figure out the best option for you. Okay. There are also great resources for patients and family online. So the 2 major groups we work with almost on a daily basis are Cholangiocarcinoma Foundation and Lisa Cream Foundation. So they help support patients, provide educational resources, videos, and provide a lot of referrals and second opinions for patients by directly reaching out to our surgeons. So these are really great resources for patients. So in summary, gallbladder and bile duct cancers are rare, but they're very deadly with really low 5-year survival. The location and stage of tumor, as well as patient's overall health condition, dictate treatment options. Gene sequencing of the tumor allows us to develop new therapies that are directly targeting the tumor. And treatment of gallbladder and cholangiocarcinoma should really take a multidisciplinary approach involving different specialists at a center that is familiar with this type of cancer. And the best outcome we know is with different combination therapy that includes chemo, radiation, surgery, and in select cases, liver transplant. And it's really, really important patients get early referral to these centers because we can really miss the treatment window in advanced disease. And with that, I'd be happy to take some questions, and definitely feel free to reach out to me. This is my email if you have any questions.
Great, thank you so much, Dr. Wang. I have a couple questions that came in to me from the private chat. And again, for everyone who is joining us on Zoom, feel free to type your questions into the chat box. You can send them directly to Gina or me, or just to everybody, doesn't matter. And same thing to everyone who is joining us on Facebook Live, just use the comments function to ask your questions there. So the one question that I have here is there any evidence that these cancers are genetic, or that they have, that people are at risk, people are at genetic risk for them?
Yeah, so there's so much research on this, and we're constantly identifying different molecular markers within the tumor. The only real condition that we know, and there's so much study out there. The only real condition we know is in folks with primary sclerosing cholangitis. So that's inflammation of the bile duct, and we typically see this in young patients and patients with inflammatory bowel disease. And so they have higher risk for developing cholangiocarcinoma. But outside of that condition, there really isn't a hereditary link to it, and that's why there isn't a guideline for screening patients for cholangiocarcinoma. And so for patients with primary sclerosing cholangitis, we typically get MRI or gallbladder ultrasound every 6 months because we know they have risk factor for developing these cancers. But really outside of that, we're not really recommending routine MRI or ultrasound for other patients. Even patients with family history of cholangiocarcinoma, we're not routinely recommending screening just because there is also downside to really routine imaging costs and anxiety. But obviously, as we get more data about this cancer, as our understanding of this cancer evolves, we're hoping to shed more light in this.
Great, thank you. I've got a question here. It says, if you don't have a gallbladder, are you at a higher risk of getting bile duct cancer?
Not necessarily. Again, I don't think we have study on folks who have their gallbladder removed to see what their risk of developing cholangiocarcinoma. And most cases of cholangiocarcinoma, we don't really know the risk factor. So about 70%, we don't really know why or how. And this tends to be the patients we see in our tumor clinic is usually someone who's really fit and otherwise healthy and not a smoker and really never drink alcohol. And their question for us is usually, how did I get this? And we don't really know. It could be environmental exposure, it could be some sort of unknown condition that perhaps we will know more as we get more research in this area.
Great. I've got a question here about, so you had mentioned that endoscopy was kind of how you can see these cancers. So would a bile duct cancer or a gallbladder cancer show up on a colonoscopy, or are those just two totally separate?
Yeah, so colonoscopy only allows us to see the colon. So that's really the best modality we have for colon cancer screening, colon cancer prevention. The endoscopy I mentioned, I can go back to the slide. Hang on, sorry, let me go back. Okay. So this is from upper approach. So this is upper endoscopy. So it's more advanced endoscopic study. So the scope is actually inserted in the mouth and goes down the esophagus. Because our liver and bile ducts sit so high up, the only way to really access it is through the small intestine, the first portion of the small intestine. So that's the extent of the endoscope. Colonoscopy is sort of the distal end of your digestive tract. So two separate study. And sometimes people get upper endoscope for, ulcers or stomach pain or reflux condition. That won't show the bile duct cancer because that requires a separate step where we have to thread a wire inside and inject contrast and take an x-ray. So that's a specific procedure. Only a few endoscopists at University of Chicago do. So Dr. Chapman, Dr. Siddiqui, and Dr. Waxman. So they're very familiar with doing this procedure. And usually there's indication for it. So if we see abnormality on ultrasound or MRI, or if you have blood tests that showed you have liver enzyme abnormality, the follow-up study is typically this to see if there is abnormality inside of the bile ducts, because this doesn't show up on CT scan. So this is really injecting, almost lighting up the tree from the inside as opposed to looking at the tree from the outside.
Okay, gotcha. So endoscope goes this way, colonoscopy
right, exactly.
goes the other way.
Yeah.
We just hear, I feel like when you talk, we talk about colon cancer and stuff, you hear colonoscopy and endoscopy being talked about, used a lot. So that's interesting to see that they can't quite see the same things. I know that you had mentioned, excessive alcohol use as a risk factor maybe for some of these cancers. So then, would you say that, especially because we know how alcohol interacts with the liver, would you say that heavy drinkers then are at higher risk of these cancers than non-drinkers, say?
Yeah, so heavy drinker, so alcohol causes scarring of the liver, and it's interesting, not only cholangiocarcinoma is, we also see hepatocellular carcinoma. So that is liver's cancer. So that is cancer not in the tree, but in sort of in the liver outside of the bile duct. And so we see that in a lot of our patients with cirrhosis. So cirrhosis is when you not only just inflammation of the liver, you have scarring of the liver that's irreversible. So liver is really an amazing organ in the sense it could regenerate. So, for our patients who have heavy alcohol use, and we see that they have some scarring of the liver, either based on blood tests or on ultrasound, we usually counsel them to stop drinking, because an early stage, if you stop drinking, that can actually reverse a lot of scarring, a lot of the inflammation. However, if people continue drinking, the scarring at one point, the liver sort of reaches a point of no return, and so there's no reversal of the scarring, and so people have cirrhosis. And so a lot of cancer comes from inflammation and scarring. And so, and when you have cirrhosis of the liver, then you're at much higher risk for hepatocellular carcinoma, so liver cancer, as well as cholangiocarcinoma. And that's some of the cases we are seeing in our liver clinic. And definitely not only from cholangiocarcinoma standpoint, from liver cancer, from cirrhosis standpoint, we always counsel our patient to, reduce heavy alcohol use.
Great, thanks for that explanation. So we have a lot of different speakers on here that talk about, risk factors for whatever cancer we're talking about, breast, colon, cervical. And so, we hear a lot about, you want to have an overall healthy lifestyle, which doesn't include things like smoking and excessive drinking. And this is, to my knowledge, the first cancer that we're hearing about where really excessive drinking is quite a pointed risk factor there. So that's really good to know, and good for us to definitely be aware of how the role that plays. And I had a question that just actually came to me about, you said that the liver is did you say it regenerates? And I had a question, and this is something, it just jogged my memory. I remember seeing a call somewhere for someone that was looking for a liver donor. And someone was saying, well, yeah, it's very safe because the liver regenerates. Could you talk a little bit about that, about liver donors and how that works, I guess, if the liver regenerates?
Yeah. So if you look at this picture, so we have, so this is sort of looking at patients. So this is the right side of the liver. This is the left side. So there are two big lobes. And like our skin, liver is something that regenerates, meaning that if we cut out a portion of the liver, the rest of the liver could grow and take over the function of the entire liver. And sometimes our surgeon would say they can actually see it in the operating room during a liver transplant. And so during a liver transplant, we're really taking out a part of the liver to give it to the recipient. And so the rest of the liver, they could see it growing. And usually by a few weeks, the liver sort of grows back to its normal size. So it doesn't grow the old portion. It's just the remaining liver cells regenerates, and you have a healthy liver again. And so at the University of Chicago, we are a big liver transplant center, and we're doing both deceased and living donor evaluations. And we have had a few patients who underwent living donation this year, and we always, more than happy to talk about living donation, because it's really a wonderful gift and it's a second chance in life for our patients. And so for our donor, usually we evaluate donors just to make sure they are healthy overall, that they don't have a lot of comorbidities in terms of diabetes, obesity, or heavy alcohol use, because the last thing we want is to take out a majority of your liver if you have risk factors for having liver disease yourself. And so the way liver transplant works is that we take out a big portion. So because it's a tree, basically you have multiple different bile ducts, you have multiple different blood vessels. So we could safely take out part of the liver, leaving the remaining liver intact with all its vessels and bile duct and drainage and all the plumbing in place. And we could even take up to 80–90% of the liver, leaving 10–20%. And that 10–20% is enough, and it will regenerate, will grow, and usually people do very well after.
That is fascinating. Wow, that is so different from like a kidney transplant or something where you're just taking out the whole thing and giving it to someone else. That's fascinating. Wow, thanks so much.
I was going to make a comment about that as well. When you said that in 2 weeks, like I knew it regenerated, but I had no idea it was like in 2 weeks. And you're saying like even in the operating room, they can kind of see it starting to do that. So that's I agree, Leah, very fascinating. And that goes into the question I had. As I mentioned, I had a neighbor, and she was Puerto Rican and Black. So that she does have that Latinx heritage that you mentioned. But I realize that the liver and the gallbladder are right next to each other, but that's actually, they diagnosed her with liver cancer first. And I had never heard of a mistake like that before. Is that common to make a mistake like that?
Yeah, because the gallbladder and the liver sits so close together, and they're somewhat connected. They're connected through the biliary tree, through the bile duct. So liver is the organ that makes bile and gets secreted to the bile tree, and then it gets stored here. So they're all connected. And so because they're so connected, the gallbladder cancer easily could spread to the liver. And usually when it spreads to the liver, and that's what we see on ultrasound, we see a mass on the liver, and typically people will call that a liver cancer. And the terminology also gets confusing because cholangiocarcinoma, it is a liver cancer because the bile tree sits in the liver. But when people say liver cancer, it could also mean hepatocellular carcinoma, meaning that cancer in the liver, but outside of the tree. And so the terminology gets confusing when people say, I have liver cancer, but it could mean cholangiocarcinoma. So cholangiocarcinoma in the biliary tree could spread to the gallbladder, and gallbladder cancer can also spread to the liver because they're so close together. And so I'm not entirely sure if she was actually diagnosed with cholangio that spread to the gallbladder, or gallbladder that spread to the bile tree into cholangio. So sometimes it's hard to know which one started first.
Okay. Makes total sense.
Do we have any other questions for Dr. Wang? I'm going to check on the Facebook comments real quick. How about anyone else on our Zoom? Any last questions for Dr. Wang? And I don't see any on Facebook. And I don't see any in our chat. Dr. Wang, if you wouldn't mind sharing those links to those resources that you had, if you wouldn't mind copy and paste and just throwing those in the chat for everyone to have, just so they can be aware. And just a huge, huge thanks to Dr. Wang for such an informative session. Like we said, this is just not a common cancer that people talk about, and wow, I learned a lot. So thank you so much for joining us today. And we really appreciate you taking time out of your hectic schedule to be here with us.
Thank you so much for having me.
Sure thing.